Get started. Welcome to our IDRPP project ECHO. This one is for our MHIDD project specifically. If you are new to us, I will give a brief introduction for myself. My name is Rachel Byers. I'm the project coordinator for our MHIDD Utah Training Initiative. That MHIDD acronym stands for Mental Health and Intellectual and Developmental Disabilities. This project focuses on improving mental health access and outcomes for people with intellectual and developmental disabilities. So this is our second ECHO series. We did have one that spanned 2023 to 2024, that fall to spring, and you may have attended some of those. If so, we're glad to see you back. Thank you for joining. And if you're new, welcome, and we hope you'll attend some of our future sessions as well. If you would like, you can drop your name and contact info in the chat as a way to follow up with other attendees and do a little bit of networking while you're here. Our last series was a general series for disability service providers as well as mental health providers. We covered some pretty broad general topics. This series has been designed with support coordinators and care or case managers specifically in mind. Our topics were chosen by a group of support coordinators and a self-advocate who is part of our planning team. That being said, anyone is welcome to attend if you are interested in our topics. So if you are not a support coordinator or a care or case manager, you're welcome and we're happy to have you here. You just may not find that everything is applicable to you. And if you know other support coordinators or care or case managers that you think would benefit from this, please feel free to share the info with them. We would love to see them. All of these sessions are recorded. That's for learning purposes on our end, so I can improve my facilitation, and also so that anybody can come back and review the session if they'd like to look at the materials, or if they were unable to make it but had registered and would like to watch it later on. So if you do not wish to be recorded, you can exit the session at any time. A few housekeeping things. We've been in the Zoom world for a while, but if you would like to change the name on your screen, or if you need help with any of those technical pieces, you can message me directly and I can help with that. There may be times throughout today's session that Beth, our wonderful presenter, asks for participation from you all. At that point, you're welcome to unmute. You can raise your hand if you would like to. If you're not quite sure how to do that, I can also help send some instructions on that as well. Basically, reach out to me if you have any Zoom technical questions and I will help you get those figured out. Because this is an ECHO session, which is focused on discussion and is kind of a community of practice style, we tend to have some discussions about individuals that we work with. We have a case presentation at the end. You are welcome to talk about your current work experiences, anything that's going on. We just ask that you protect individual privacy. So if you're talking about a person or a case that you're currently working on, just avoid sharing any identifying personal information such as their name, contact info, or family members, anything that might identify them. If you want to share something and you're not quite sure if you should or what you should divulge, you can again message me and I will help figure that out. I mentioned just briefly previously, this is an ECHO session, which is different than a traditional webinar where you may log on and turn off your camera and just be silent for 45 minutes and then move on with your day. We are hoping that this is more engaging for you. It's intended to be more interactive, and it really works out best when everybody participates, shares your thoughts and experiences. That's when we learn the most from this. So I encourage you to participate, especially in the didactic session while Beth is talking. She may ask for some input, and then particularly when we have our case discussion after that presentation. So please feel free to share and discuss. We would love to hear your experiences, especially during our case discussion later today. We do also accept case scenarios from you all, potential participants. If you have a case that you're working with currently, or even one in the past that you're like, this might have been good to have a group to discuss with, you can submit that to me and we'll discuss it as a group at our next meeting. So that may be of interest to you if you'd like some input from other support coordinators or other professionals on something that you're working on. We will start out with the didactic presentation for Beth, who I will introduce shortly, and that will be followed by a case presentation and some group discussion, as I mentioned previously. Those are just the key components of what we're doing here in our ECHO session. Another plug for those case studies. If you would like to submit a case scenario for discussion, you can send that to me via email. I will drop my email in the chat so you have that. We also offer certificates of attendance or CEUs from the Utah Social Work Association. I know a lot of you all are licensed social workers and may appreciate that. They are free. We have covered the cost for those. If you would like a certificate of attendance or a CEU, all you need to do is fill out the survey for today's session. We'll drop that link in the chat at least one more time today so that you can access that. At the end of that survey, you'll have an opportunity to identify if you want a certificate of attendance or a CEU or both. And even if you don't want one of those, we would really appreciate it if you fill out the survey because it gives us an opportunity to learn and improve what we're doing. You may have noticed if you've joined our series previously, there is a new platform that we're using to host these sessions and keep everything organized. If you're here, that means you successfully created an account with iEcho and joined the link. But if you do have any questions about that platform or navigating it, that's another thing that you can reach out to me about. And another plug for our social media. This isn't the only ECHO series we have going on at the IDRPP. We have several you may be interested in. This QR code will take you to our social media. We are on Facebook and Instagram. Our next session is slated for September 9th. We are finalizing that topic and we'll have info sent out with details as soon as possible. All right, and I'll give a brief introduction here. We are super, super lucky to have Beth Barrasso with us from the National Center for START Services. She's a macro social worker with over a decade of expertise in the field of intellectual and developmental disabilities and mental health. She has experience in leadership, curriculum design, training and professional development, care coordination, outpatient therapy, and clinical supervision. As the Director of Training and Professional Development at the National Center for START Services, she oversees a robust training and professional development department that offers both START-focused training and certification, as well as IDD-MH training and professional development for the community at large. She has served as the co-chair of the annual START National Training Institute since the inaugural training in 2016. Beth is passionate about issues related to cultural competency, diversity, equity, inclusion, justice, access, and belonging. She has previously served as the Stakeholder Engagement Coordinator in START research projects and continues her commitment to elevating the voices and perspectives of people with lived experience of IDD-MH. When not at work, you can find Beth spending time with her two awesome kids, reading and enjoying live music. And I will turn over to you, Beth. Please feel free to add your intro if I missed anything. And
I don't think that will be necessary. Thank you. Oh, thank you, Rachel. And hello. Good afternoon. I'm on Eastern time. I think you all are on Mountain time. So happy noontime and lunchtime. Feel free to snack away while we talk today. So Rachel, thank you so much for that very glorious introduction. Today, we're going to be talking about understanding mental health concerns and IDD, and we're going to use the acronym IDD-MH when we're talking about that. And I wanted to note that the content from this presentation has been adapted from our professional development course for care coordinators and case managers around the mental health aspects of IDD. So this is sort of a sneak preview. And we have a cohort of that course starting Monday, October 7th. And at the end of this presentation, I'll give you some more information if you're interested in registering. Our partnership with the IDRPP allows you to access that course with no registration fee for you. So it's quite an opportunity. So let's get started. So we're going to get started. And before we do that, it is very important to me that we frame today's session in the values and principles and approaches that guide our work and our thinking here at the National Center for START Services, and more specifically within the evidence-based START model. I'm not teaching about START today. I'm teaching about the mental health aspects of IDD, but the START model has a firm commitment to these guiding values and principles, and it really shapes the way that we teach in our professional development courses as well. So you see this humanistic approach, which means that our approach is based on our shared humanity, right? It's one that actively affirms the dignity of every human being and really works to maximize self-determination, which is a term and a concept that you're likely familiar with already, where people are able to live self-directed, meaningful lives in their communities of choice, right? This is a core value of the disability rights movement as our work. The next is this biomedical, psychological, social, cultural, spiritual lens, right? And this helps us to think about and view each person as a whole person. And it's rooted in the knowledge that as humans, there's always a very complex interplay between these different aspects of our human experience. And we'll talk more about that later on. A trauma-informed approach and an approach of cultural competency and humility. And I say those two together because they are deeply interconnected. Adopting a trauma-informed approach isn't really accomplished through any singular particular technique or a checklist, right? It requires our constant attention, a caring awareness, a sensitivity, and potentially a cultural shift at an organizational level, right? And so cultural humility, which is a term that I tend to gravitate toward, isn't just an approach, it's really a practice. It is a practice of our own self-reflection and maintaining this position of openness to understanding other cultures, other ways of being, thinking, and doing. And it also acknowledges power imbalances that exist in society, and that's super relevant when you're talking about disability, right? And a demonstration of cultural humility is central really to our work in centering the narratives of people and families with the lived experience of IDDMH, honoring them as the experts in their own experience. And then finally, positive psychology, which includes PERMA, which is a model for well-being, and it's an acronym that stands for positive experiences, engagement, relationships, meaning, and achievement. And those four elements really combining to create what we would consider the state of well-being. Right? Character strengths are those strengths that we all possess within us, and leveraging character strengths in the pursuit of PERMA for the people that we support. Right. And a positive psychology approach is very much aligned with a trauma-informed care approach, placing the emphasis on healing and resilience and really getting to flourishing rather than just eliminating the negatives or eliminating the challenges, right? It's about building the intrinsic strengths of the person and not just being nice and kind or saying, let's all just be happy, right? So today I'm going to give you a quick overview of what we mean when we talk about IDD and genetic syndromes, which are tied into that categorization. We're going to talk about vulnerabilities. What are they and what are some common vulnerabilities amongst people with IDD? We're going to take a closer look at executive functioning. And then we're going to move into mental health and IDD. What is the prevalence? What are some common symptoms? And what are barriers, right, to diagnosing, to treating, and to engaging with people and families who are experiencing a mental health need, which will bring us to what helps, What are some common core solutions? And then we're going to move into Harmony's vignette, which you were shared. And so this slide is just a reminder or a prompt that this vignette was emailed to you, I believe, earlier today. And so if you don't have it pulled up, now would be a nice time to pull it up. If you haven't read it, that's okay. We'll take an opportunity to do that later on during the case segment of today's session. But just keeping Harmony top of mind as we move through today's content. All right, so we're going to start with the basics, and I want to acknowledge that this is likely information that's very likely widely known, right? And we are revisiting these definitions intentionally to serve as the foundation for our understanding as we start to move into understanding mental health in people with IDD. So we'll start with developmental disabilities. So this clinical definition is on the blue and green here, and it's defining characteristics, right? So we know that a developmental disability manifests before adulthood. It's likely to continue indefinitely, right? It results in functional limitations and tends to indicate the need for long-term supports. Some examples of developmental disabilities are autism, cerebral palsy, fetal alcohol spectrum disorder. A traumatic brain injury that occurs before the age of 22 would be considered a developmental disability, and some genetic disorders, such as Down syndrome, Prader-Willi, Fragile X, and we'll get a little bit into that in a minute. And so intellectual disability is a developmental disability and has its own defining clinical criteria. And one myth that I like to bust is that intellectual disability isn't just about your IQ score. It also confirms that there is a need in the realm of adaptive functioning. And so you'll see here this deficits in adaptive functioning header, right? Failure to meet developmental and socio-cultural standards for personal independence and social responsibility. And that without ongoing support, the adaptive deficits limit a person's functioning. This is verbiage from the DSM-5. As case managers, we are not diagnosticians, right? But it's important for us to have context and understand how the people that we support came to us, right? Where they are. And I just wanted a note to tie into our guiding principles and values here. Take a look at those words, developmental and socio-cultural standards, right? What is considered typical in our society? We place a really strong emphasis on independence. Not all cultures do, right? And so how that factors in to how a person is evaluated and how their adaptive functioning needs are determined is something to consider. Adaptive behavior is broken out into 3 different domains. We have conceptual skills, which is like how our language that we use, our understanding of things like money and time, number concepts, and how self-directed we are. I would note too that time is a cultural phenomenon, and how people experience time and conceptualize time often varies across cultures. Within the social skill domain, this is where we're talking about those interpersonal skills, concepts of social responsibility. There's that term, right? Person's self-concept, their self-esteem, the gullibility, right? One of the things that we often talk about when we're talking about supporting people with ID is their naivety, right? And ensuring that when we are promoting the most independent community-based life that we can possibly provide, that we're also making sure that we're providing that person with the skills and tools they need to protect themselves against exploitation, right? And then practical skills, these activities of daily living, your personal care, your ADLs, how you access your doctor's appointments, how you utilize transportation, how well you can develop or adhere to schedules and routines, your concept of safety, things like that. So these are the 3 domains of adaptive behavior that are evaluated when a person is diagnosed with an intellectual disability. And it's the deficits within these 3 domains that tend to get overlooked, right? And I'd like to reframe our concept of deficits and really think about support, right? What are this person's support needs? And what support needs does a person have that will ensure that they're able to live their most meaningful life? So this is a question that you are free to answer in chat. And I have chat open, I can see it. Why is it important for us, do you think, to understand genetic syndromes when it comes to mental health? Why is it important for us as care managers or care coordinators, case managers? Why do you think it's important for us?
I think it's important to understand them because if they have a genetic disorder, their behaviors are typically intertwined with that genetic disorder and are not necessarily in relation to a mental health problem. Same with autism spectrum disorder. All those things come with behaviors that can resemble mental health diagnoses, but not all of them are going to be mental health diagnoses. It could be something related to that condition.
Excellent. Thank you so much. I can't see who said that, but that was fantastic, and thank you. Corrine in the chat said to help with medications, right? To understand what meds may be indicated or contraindicated, right? To help with understanding how their body works. Excellent foreshadowing, Corinne. Debbie, for setting up expectations and supports, right? What do we understand about the nature of this genetic syndrome? In order for it to be a syndrome, we have some foundation of understanding about what it means, right? So you are all correct. Prevalence for first of all, we need to understand that both autism and genetic syndromes are frequently seen amongst people with IDD, right? So it's a prevalence issue. This is something that is often present, and it can help to inform the appropriateness of supports and services. So there you go, right? Both genetic syndromes have both behavioral and physical phenotypes or characteristics that need to be considered during our assessment, our diagnostic process, and it informs how we provide support and treatment, which you all spoke to. So you are ahead of the curve here, right? And so here's an example, right? Knowing that a person with Down syndrome who is hallucinating is more likely to have major depressive disorder with psychotic features than, say, schizophrenia, and that the underlying cause might be hypothyroidism is really important to treatment. And that's exactly what our group member today who spoke was articulating, right? It may look like a mental health condition. And in the absence of understanding the nature of the physical and behavioral phenotypes of a genetic syndrome, we risk misdiagnosis. And that can have really significant implications for how we go about providing support to a person, as well as treatment, especially psychopharmacologically. And we're not going into that today, but a point for consideration. So autism spectrum disorder, and I'm going to run through this rather quickly because again, I think that this is shared knowledge, but again, it's serving as a foundation, right? A lot of the people that we support with intellectual disability may also be diagnosed with autism spectrum disorder, but not everybody who has autism has an intellectual disability, right? Right now, the incidence of autism is about 1 in 36 per the last CDC's reporting. The cause, the etiology of autism is still being researched, but the most current research is suggesting a complex interaction between genetics and environmental factors. Why has this incidence risen? This is also a cause for a lot of speculation. What we like to sort of stay in the zone of truth is that we have better diagnosing protocols and we have better early intervention, right? And it's important for us to understand and have a good understanding of what autism looks like, right? In order to prevent misdiagnosis of psychiatric symptoms that may actually be more reflective, but not always. So to that end, the DSM-5 identifies that the core sort of characteristics of autism are social communication and social interaction deficits and restrictive or repetitive patterns. These have to be present, again, in accordance with the diagnostic criteria of a developmental disability, and they cannot be better explained by an intellectual disability, right? I also just want to say here that you may have heard this common phrase of, if you've met a person with autism, you've met a person with autism. Understanding the clinical criteria and the common characteristics of autism are very important. But let's go back to that cultural humility value, right? That's undergirding what we're talking about today. It's just as important to ask yourself and explore, what does autism look like for each individual person that you support? It does not look the same across each person. So genetic syndromes, and I will pop this link into the chat when I have a moment to do so. You will also get a copy of this PowerPoint, so you'll have access to this resource, which is a wonderful resource that provides very accessible, down-to-earth overviews of many common genetic conditions. But there are a range of genetic syndromes that intersect with IDD. This list is just a few of them. So we're going to just focus on a couple common examples, and that is, we're going to start with Down syndrome. And what we see in folks with Down syndrome, common physical features: small stature, small ears and mouth, a tiny upward slant to their eyes, low muscle tone is very common. And then medically and behaviorally, we know that people with Down syndrome are more likely to experience congenital heart disease, hearing problems, thyroid problems. They also have a proclivity toward dementia and early onset dementia. And so that's important for us to understand as well. So fetal alcohol spectrum disorder is technically not a genetic syndrome. It's a neurodevelopmental disorder, but it shares similar traits. For example, behavioral and medical phenotypes. And this is also a disorder and a diagnosis that we see a lot when we are working in the IDD space, right? So its cause is intrauterine exposure to alcohol. You can broaden that to any type of teratogen or harmful substance that introduces itself within that in utero period, right? Common physical characteristics include a small head circumference, small eye openings, wide set eyes. One of the hallmark sort of physical features is a smooth philtrum, and that's that space between your upper lip and your nose here. And so most folks have a little groove there, and if it's very, very smooth, that can be a physical characteristic. They may have poor coordination. Medically and behaviorally, they may also experience heart defects, kidney dysfunction, vision or hearing difficulties. Behaviorally, multiple executive functioning deficits. We're going to talk about executive functioning, poor memory, reason. The disconnect between cause and effect is very significant in people with fetal alcohol spectrum disorders, right? So they can make a mistake and engage in some debrief and processing about it and demonstrate a very clear understanding, and then go and make that same mistake again. And that can be very frustrating for service providers and can also lead to mislabeling of it as intentional or manipulative, when in fact, this is one of the core behavioral features of fetal alcohol spectrum, right? And there's a little hint here about Harmony. Harmony may very well have fetal alcohol spectrum disorder, right? How does that inform the way that we think about her and approach her care coordination needs? So again, these are some behavioral signs across different genetic syndromes. Folks with Williams syndrome have been known to have some very specific or unusual phobias, like thunderstorms, right? They also tend to be characterized as very, very social, outgoing, right? Not all behavioral signs are negative, right? So case in point, Williams syndrome, very outgoing personality. The same might be said of folks with Down syndrome, right? There are a range of physical signs to notice, and I'm not going to walk through each item on this slide. You will have access to this as a reference point. This is to say that physical signs are merely cues for you to ask questions. If the person does not have a genetic syndrome, but they're displaying this very sort of consistent thematic behavioral repertoire, right? And they have some of these physical signs, it might just be a cue for you to ask questions, things that might make you wonder aloud with the team, or ask, has this person ever had genetic testing? So all this talk about behavioral and physical and medical needs and phenotypes really sort of serves as the premise for understanding mental health in people with IDD. Just as it is for all of us, we all have vulnerabilities. People with IDD experience them at a higher intensity and frequency, which makes it especially important for us to consider. So vulnerabilities are going to be different for every person based on their history. An example of a vulnerability from a biopsychosocial perspective would be that a person has a history of trauma and is very anxious, hypervigilant, right? And she does best with a really consistent routine that offers them this sense of predictability and safety that helps them to engage actively in their own lives. And a trigger would be the sudden change in schedule, right? Understanding a person's vulnerabilities helps us to mitigate the impact of triggers by making a proactive plan and not just relying on conditional reactive responses, right? So vulnerabilities are characteristics of a person that predispose them to experience stress or mental health issues. So there's a lot on this slide, I know. But this represents just some of the biopsychosocial vulnerabilities that may increase risk for crisis for people with ID. These are some, they are not all. This is not an exhaustive list. But you can also see from this Venn diagram that there's an overlap amongst the domains, right? So for example, executive functioning has both biological and psychological implications. And this overlap demonstrates the importance of using this biopsychosocial approach that recognizes the interplay between all of these domains. Right? So in the social domain, you see issues with housemates, right? A lack of a sense of belonging, right? Feeling that perpetual feeling of otherness, changes in staffing, unexpected changes in their routines, conflicts with cultural values or norms that perhaps they were raised with that are different from where they're living now. In the psychological realm, we're talking about receptive or expressive communication differences. How well do we understand that? How well do we understand how well a person takes in information versus how well they express verbally, right? And sometimes there is a disconnect between those two. And that can also lead to misdiagnoses and misattributions, right? When it comes to mental health. If a person can speak verbally better than they can process, that can lead providers to believe that there is this this level of intent that truly isn't there, right? And biomedical. What are the existing biological or medical needs that this person has that need to be considered as a vulnerability that predispose them to stress and responding to triggers in their lives? So the social determinants of health are really the conditions within a person's environment where people are born, where they live, where they work, play, engage with each other, that impact a wide range of health and quality of life outcomes, right? And this is an existing framework. I didn't make it up and START didn't make it up, but this framework complements the biopsychosocial model really nicely. And I often will reference these domains when I am working with a team or when I'm considering social aspects that are surrounding a person, right? For thinking about a person from sort of an ecological perspective, a biopsychosocial perspective, what's their neighborhood environment like, right? What kind of social support do they have available to them? Not just paid support, but natural supports, right? What types of discrimination might this person experience in their day-to-day lives, right? What about historically? Loneliness, you can see, is on here. So this is, again, this is a public source image. You can use it. There's lots of additional information about social determinants of health, but encouraging you to factor this into how you are thinking about people with IDD and their mental health needs. So executive function, we've already highlighted this as a vulnerability, and this is executive functioning originates in the prefrontal cortex or the frontal lobe region of the brain, which we know is more sensitive to stress than any other, and this is where executive functioning originates, right? Many studies have shown that people with a developmental disability of any cause have a deficit in executive functioning. And just to mitigate that statement a little bit, we all experience executive functioning deficits too, especially during periods of stress, right? Think about that. Think about when you're stressed, how easy is it for you to organize information, to regulate yourself, right? So executive functioning is a set of mental processes that helps us to connect past experiences to present action, right? How has something that I've experienced in the past, how can it inform what's happening to me right now? Remember how I talked about cause and effect and fetal alcohol syndrome? That is executive functioning, right? And this helps us to adapt and engage in our lives by being able to pivot really quickly, right? An unexpected situation comes up and we can make a new plan. And typically that happens in a pretty seamless fashion. So what do executive functionings, how do they show up, especially in the lives of people with IDD? It might look like impulse control, right? It might look like their ability to regulate their emotions. You might see these big reactions, these big feelings, right? For something that seems relatively small. Flexible thinking, right? Shifting sets, being able to jump from one topic to another, right? Working memory, so short-term memory, learning from the past, cause and effect, being able to self-monitor themselves, planning and prioritizing. You know, what's the order that I need to do things in? I got a full to-do list. What needs to come first? And on that note, task initiation. Where do I start? Right? And this can sort of be, I call it the analysis paralysis, right? Like you have so much on your to-do list and you're so overwhelmed, right? Where do I start? I got to start somewhere. And organization. So that might look like losing your train of thought within a conversation. And it could be also, you know, losing track of items, right? Your personal belongings. So stress is an inevitability of life, and our goal is not to eradicate stress, but to recognize it and the role that it plays in all of our lives. And this is something I think that we sometimes forget or don't pay proper credence to in the people that we support, that we all experience stress. Right? And executive functioning and anxiety can actually undermine our ability to cope with stress. And so the external resilience that we offer through our delivery of support, our coordination of support and services, that is really key. So some common stressors in the lives of people with IDD, like I said, changes to staff or key service providers, which happens all too frequently. Changes in the type of contact, right? Maybe a family member was coming to visit once a week and now they moved away and they can call, and maybe they call once a month, right? A move to a new living situation. It can also include inconsistent approaches across staff if a person has different staff at different times. Changes in routine can also be really stressful for people with IDD. So let's talk about IDD and mental health. I put this quote in to the right in this pink, purpley, gray box. People with IDD are underdiagnosed, not treated, or inappropriately diagnosed with mental health needs. And we're going to explore that statement a whole lot more right now. Around 30 to 40% of all people with IDD have a psychiatric disorder. And that is a bit higher than the general population, which hovers around 27%. 10 to 20% of people with IDD have some form of challenging behavior, whether that's self-injury or physical aggression or property destruction that is severe enough to impair their daily lives. And symptoms of mental illness in people with ID can present differently in people with ID. And that can contribute to difficulty in determining appropriate psychiatric diagnoses and treatment plans. We're going to talk more about that right now. Before we do, medical conditions, biomedical, the bio and biopsychosocial. Mental health or behavioral problems can also be symptoms of a medical condition, right? So we talked about genetic syndromes and understanding that. The externalized behavior may also be communicating pain, ear infections, UTIs, symptoms related to uncontrolled diabetes, a seizure disorder, which are very common in people with developmental disabilities, a thyroid disorder, right? Complex behavior problems can be caused or maintained by a combination of factors. Behavioral problems can also arise as a result of past traumatic experiences. And we also know that the prevalence of trauma amongst people with IDD is very high. One of the cornerstones of a trauma-informed care approach is sort of this universal precautions approach, right? That it doesn't harm anybody to use a trauma-informed care approach, even if you're not sure if they have experienced trauma, right? And that's important because in light of the prevalence of trauma amongst people with ID. And we're talking little t and big T traumas. Medications can also play a major role in a person's behavioral presentation, right? The presence of too many medications, not the right medications, or side effects of medications can also impact the way that a person presents, the way that they are observed by others in their lives, family members, providers, right? So we always want to rule out medical issues first. People with ID may also have a smaller window of tolerance, and that's that area in the middle here, right? They will be going outside this window of tolerance more often than someone who has better executive functioning, right? So we must recognize that this window is smaller for people with ID, which means that they are going to be in this hyperarousal or hypoarousal state more frequently than a person who has a bigger window of tolerance, right? This window of tolerance is where we are able to think and feel at the same time when we are regulated, right? So what causes a high risk for aggression or behavioral challenges, as well as mental health diagnoses in people with IDD? One of them is poor functional communication, right? The way that they are able to self-report. And this includes even people who speak in full sentences, right? And we have to ask ourselves, are people missing the role of cognitive vulnerabilities? I mentioned sort of that gap, the chasm between a person's expressive and receptive language. How well is that understood? Has that ever been looked at? The next is a limited behavioral repertoire, and that's in quotes. What it really means is that the person may not have enough coping skills, right? They have very few ways to convey that they're stressed out and they're outside of their window of tolerance, right? And they have very few ways to control the events and circumstances around them, and that is a socio-cultural consideration. How much control do they have over their schedule? Likely, other folks are in control of a large part of their day. That doesn't mean that that's the way that it should be, but it is a reality to consider. So the question in red would be, do people in this person's life understand the help that's needed for this person to manage their stressors? Another cause might be lack of meaningful engagement, limited choices. Others choose what they're going to do. And so in red is a question that you might ask. Does this person have things to do that bring them happiness and a sense of meaning and purpose? And then the final reason that causes a high risk for aggression or mental health diagnoses are difficulty with emotional regulation and executive functioning, especially related to problem solving and planning. This causes a higher level of stress and emotional dysregulation. You may already be aware of this, but this is my plug for the DMID2, which is an accompaniment to the DSM-5. As a former care manager, case manager myself, and a supervisor of a case management department many years ago, I can tell you that I use the DMID2 rather frequently. I wasn't a diagnostician, but I was curious. I was curious about the people on my caseload, on the case managers that I was supervising, and what the manifestation of their behavioral symptoms or their mental health needs how it may be interpreted, right? The DMID runs in tandem with the DSM-5 and gives you adapted clinical criteria for people with intellectual disability. Check it out if you haven't. It's a wonderful resource for your bookshelf. All right, so prevalence of mental health and IDD. We've talked about percentages, and now I have a question for you. You can unmute, you can use chat. What are the 3 most common mental health diagnoses for people with IDD? And this is with the acknowledgement that people with IDD experience the full range of human emotions and therefore the full range of psychiatric disorders experienced by people without disabilities. So what do you think are the 3 most common? Mandy, depression and anxiety. Tia, PTSD. Anyone else? ODD. ODD stands for oppositional defiant disorder. Bipolar disorder. Iman, thank you. OCD, obsessive compulsive disorder. So in the interest of time, Audra, I see you, ADHD. The 3 most common mental health diagnoses were the top 3 that came in. Trauma, depression, and anxiety. Trauma or stress or related disorders. There's a few of them under that category. And bipolar disorder and psychosis are far less common. And yet we see such a preponderance of them, especially amongst people with IDD who have some really significant externalized behavior, right? When bipolar disorder and psychosis occur in people with ID, and it does, it's very severe. I don't know why this slide does this. There we go. So factors that can make psychiatric diagnosis more difficult in people with ID. So we talked about cognitive abilities, right? Limits the person's understanding of questions and answers and their ability to self-reflect, which is the primary modality for typical mental health evaluations, right? You're relying on informant report. There are challenges with receptive and expressive language. Their ability to articulate abstract concepts like symptoms, which is what you rely on to make a diagnosis, right? Like I'm feeling really down today, or I've, had been consistently pretty depressed for the last week. And that may not be something that a person with an intellectual disability can articulate. There's also this sociocultural phenomenon of acquiescence bias. Due to power imbalances and sociocultural norms, people with ID might feel like they need to please others by remaining in agreement. So there might be some yesing, which can lead to an inaccurate assessment. Then we see atypical symptoms and presentation. So a person who has experienced a significant amount of trauma, it may be misperceived as psychosis. Anxiety may be misperceived as noncompliance. So we're going to quickly run through a couple of identified phenomena when it comes to these barriers. And the first is diagnostic overshadowing. And I'm sure you've all experienced this. I can't see you, but I'm sure you're head nodding, right? And this is the tendency to attribute all behavioral, emotional, and social issues to a diagnosis. And what this looks like is a person with ID presenting at an emergency room and being told that it's because of their autism, or it's all behavioral, right? The presence of a IDD tends to overshadow the potential existence of anything else, right? A mental health condition, even a medical condition. I bet if we had time, you'd be able to share a story of a person who had a medical condition that was overlooked, right? That's diagnostic overshadowing. Baseline exaggeration. What this means is that there might be a challenging behavior that exists at a really low rate and low intensity. It's super manageable, that might increase dramatically when a person is reacting to stress or the exacerbation of a mental health condition, right? And for people with ID, that behavior then becomes the focus of the referral. So a person's in the ER, they're hitting their head. The family reports that he does hit his head when he is stimming, right? But he was brought in because there was a change in this behavior, which was a cause for concern, right? So usually he might just tap his head as a stim, but now he's hurting himself, right? And the doctors might be dismissive of that and say that is autism, that is stimming. That is not behavioral, there's no cause for concern. But it's that baseline exaggeration that they're reporting. Intellectual distortion. So due to challenges in a person's abstract thinking, questions need to be articulated really concretely. So a standard evaluation question like, do you hear voices, might lead a person with ID to think to themselves, well, yeah, of course I hear voices. I hear the voice of my bus driver and my friends and my one-to-one staff. And so they answer yes. Psychosocial masking, and this is really a misunderstanding or a mismatch of what's developmentally appropriate, right? So someone talking to themselves is misinterpreted as the person having auditory hallucinations, right? A person has an imaginary friend, and that's mistaken for a delusion. We need to sort of remember, without stigmatizing people, around, mental age theory is very harmful. So we don't want to stigmatize people or infantilize adults with ID, but we do need to understand what's developmentally appropriate, right? We need to understand that given their receptive and expressive language abilities and where they are cognitively, having an imaginary friend is very adaptive and is not a symptom of a mental health condition. And cognitive disintegration, which think back to that window of tolerance. Due to a lack of a cognitive reserve and a smaller window, people with ID might dramatically decompensate really quickly under stress. And that might lead to a loss of skills, stopping talking. They may have difficulty communicating their feelings, and this can lead to a lot of incorrect diagnoses, including psychotic disorders and such. So saying someone has a behavior problem is like saying they have a fever. And we attribute this to Dr. Jarrett Barnhill, one of our original medical advisors here at START. And all this to say that a behavior problem is nondescript. It doesn't tell us anything. Just like when you have a fever, it's nondescript. Its etiology could be a vast array of things. So it's our job, just like when we're investigating a fever, to monitor, explore, and get to the root cause. What's causing the fever? Or in this case, what's causing a behavior problem? So these are all signs and symptoms of a mental health condition. You'll note that in red at the bottom and with a strike through is aggression. Aggression is not a sign or a symptom of a mental health condition. All of the signs and symptoms that are listed do impact a person's executive functioning, though. So what can we do? Both signs and symptoms are important when we're making an accurate diagnosis, and they're often used interchangeably, but making the distinction matters when we're working to fight the barriers to an accurate diagnosis, right? So what's a sign? A sign is objective evidence that can be seen or measured by others. And what's a symptom? A symptom can only be perceived as internal It can only be perceived by the person affected, and only that person can express how they feel, right? And what we see is this overuse of labels by informants, right? We are working within a context where there are multiple providers who are contributing to an assessment or an evaluation, right? And so what they share tend to be these externalizing signs, which is normal. Again, this is not finger pointing and this is not naming, blaming, shaming. This is what happens because it's human nature. So they emphasize what they see. And then what tends to happen is that we hear labels like manic, attention seeking, right? So what comes to mind for you, and this is just going to be reflective, you can feel free to share in chat, but I'm very mindful of time. What comes to mind for you when you hear cycling, manipulating, splitting, attention seeking, manic? What kind of thoughts does that elicit? It's not an objective description of what the informant observed. It's a label, right? And it perpetuates negative impressions of the person, right? So instead, you might consider asking, when was the last time that this person was doing well? Or when a label is used, when someone says, well, that person's manipulating, what does manipulating look like for John, right? Ask them to paint a picture so that put you in that moment. What does that look like? When you say cycling, what does that look like? So what helps? What helps is building what's strong, what's going well, right? How can we facilitate more effective ways of communicating and collaborating with each other in the best interest of the person that's being supported and their family? So I've listed some resources for you, should you be interested in continuing on this learning journey. What's most important right at the top is, as a team member, as a service coordinator, that you are facilitating a very clear process of defining roles and responsibilities of team members. Facilitating a process of crisis planning so that you can be more proactive. And that you are always keeping in mind the characteristics of an open and collaborative system of care, right? Are you staying curious? Are you engaged? Do people feel like they can call one another and share information? How are they doing that? Establishing a shared understanding of the whole person, using a trauma-informed lens, using a biopsychosocial, cultural, spiritual perspective, right? Leveraging a person's strengths, skills, and interests to mitigate their biopsychosocial vulnerabilities and triggers. And a shared commitment to ensuring that every person that you work with gets to experience moments of joy, of meaningful engagement, and access to a full array of positive and affirming experiences in their communities of choice. And this might seem overly simplistic, but it's something that tends to fall to the bottom of the spin cycle, right? Especially when we're contending with problems and challenges, right? Without realizing that asking a question about what was this person like when they were doing well, or how can we introduce a moment of joy for this person, can actually be the antidote, can actually be the beginning of a new path of solutions, right? Toward well-being. And it's a process. It's a practice, right? So again, I just want to remind you that this 55-minute sort of micro session is a distillation of a session for our course for care coordinators, which is co-facilitated by two lovely experts in the field of care coordination and IDDMH. Our next cohort starts October 7th, and you can email Rachel at rachel.byers@usu.edu if you're interested in learning how to register. All right, so I think that we are transitioning into our case vignette time with a half an hour. Or do we have a half an hour to go, Rachel? I want to check in for time.
Yep, we can wrap up just around 1:25-ish and then we'll close.
Perfect. Okay. 125-ish is 325-ish. Perfect. All right, so you were emailed this copy of Harmony's case vignette, and there were some discussion prompts at the bottom. I'm going to read this out loud so that we're all on the same page. Don't worry or scramble or think that, oh no, I didn't do my homework. It's okay. And the discussion prompts, I want to preface them by saying they are entry points. And what I really want most of all is for us to engage in dialogue and discussion. How has this case vignette helped you to understand or apply what we talked about during today's session, or what questions do you still have? And we're going to use Harmony as sort of our jumping point for that. So let's start by talking about Harmony. She is a humorous and artistic African-American young woman who responds really well to structure, schedule, and routine. She loves having regular opportunities for positive recognition. She loves when she's being celebrated. She lives in a group home not a group home, a residence with a supportive family, a husband and wife who have some grown kids and they're outside of the house. She remains close to her adoptive mother, who she feels really connected to and is a really great source of support for her. Harmony does have strained relationships with her respite worker, her direct support professional, and her adoptive siblings, who really honestly struggle with how to best support her, especially when Harmony has periods of heightened anxiety. Those periods tend to lead to periods of physical aggression. Harmony has 20 hours of day hab. She enjoys spending that time with her peers, doing outdoor activities, and volunteering. She bags part-time at a local grocery store for about 6 hours a week, and she loves the interactive element of it, interacting with customers. She's pretty independent at work. She receives some support just to give her a rundown of the day's tasks and to clock out at the end of the day. She wants more hours, but she's limited to her Medicaid income. She's currently on hiatus from respite after numerous conflicts with her current provider. So Harmony was exposed to drugs in utero, alcohol in utero, and was removed from her biological family when she was 1. She has not had contact with her bio family since she was about 3. Her current diagnoses are mild intellectual disability, autism spectrum disorder, attention deficit hyperactivity disorder, oppositional defiant disorder, and an unspecified personality disorder. She is often characterized by members of her team as being defiant or manipulative. She has a history of verbal and physical aggression during periods of stress, and she will sometimes leave places unexpectedly. Harmony struggles with understanding cause and effect, especially when she's thinking about the consequences of her actions. And thus, she has also spent over a month in juvenile detention after a significant episode of aggression. So I'm going to transition to the discussion prompts now, and again, remind you that these are starting points, entry points, so you can choose to respond to any one of these, or you can chime in with your own reflection or question. So I'm going to leave space for anyone who wants to jump in, has something burning on top, and we'll start there. And if not, I'll start running down the list. What are your thoughts about Harmony? I'm going to stop sharing my screen. I'll put these in the
She's
chat.
experienced a lot of trauma, and that probably doesn't help her mental health diagnoses.
Excellent.
And that her team needs to not only support her autism, fetal alcohol syndrome, and intellectual disability, but it sounds like if they're able to help her mental health concerns, then they'd be better able to support her and wouldn't have to have as many outbursts if they can work on understanding her trauma and supporting that better.
So nice. You're really tuning into the history of trauma, right? And that seems to be pretty underplayed based on this case vignette. And Corinne, in the chat, you said it's important to recognize fetal alcohol spectrum disorder. What are you seeing there, Corinne, if you want to respond in chat or unmute?
I think it's important to note that the anxiety could be coming from that, also the aggression, the executive functioning, and all of that needs to be taken into consideration to help support her coping skills, her mental health, all of that together.
Very good. All of that, I like what you just said, like all of that together, right? We should have t-shirts that just say that, right? Because it's not just one thing. It's all of that together. So it's trauma. It's the exposure to drugs and alcohol in utero, right? It is all of those things and more, the social considerations. Lauren, you said, does she have access to mental health resources? Well, based on this vignette, no. So as a case manager, there you go. There's an opening. There's a question. So we talked about trauma, but I don't see trauma on her list of diagnoses. Anyone want to make any type of speculation around her list of diagnoses based on what we learned today?
Seems like they were more going off of her behaviors rather than herself as a whole, and we're looking at her history, and we're just looking at what symptoms were present.
Very nice. I can't see who's saying this. Oh, is it Iman?
Yeah.
Ah, thank you. What makes you think that?
Well, because the symptoms that are listed has what those diagnoses would be, but it doesn't look at her history in any of those diagnoses.
Very good. So her list of diagnoses are mild ID, autism, ADHD. So we've got our sort of neurodevelopmental disorders. Then we have oppositional defiant disorder. We have an unspecified personality disorder. And so Iman said, it sounds like they're really, basing that on the externalized symptoms, the externalized signs that are being reported, right? Because we know that her staff has previously characterized her as defiant and manipulative, right? So the labels that are being used to describe Harmony have influenced and made their way into this case vignette. And so strangers like all of us, and by the way, this is a learning vignette. So strangers like all of us can look at this list of diagnoses, and if we didn't have context or an understanding of the nuances of mental health and IDD, that would send us down a pretty interesting path for treatment and services. It may also make it really hard to coordinate services. So a lot of providers might look at that and say, ooh, tough cookie, right? And trauma's nowhere on there.
Got a few comments in the chat.
Art therapy. Yeah. Art therapy is a wonderful resource, right? So that might be something that you would discuss in the context of trauma as well, right? So sort of bringing in this consideration of trauma, which may not, depending on the provider's history with Harmony, maybe they're not aware of it. Maybe they haven't sort of connected those dots. So again, your role is not as a diagnostician or conducting an official clinical assessment, but you may have access to information that helps provide a deeper context, right? And you can ask questions and join with the system of care or the team in getting curious. and saying, what about trauma? Would we want to bring this up to her therapist or her psychiatrist at the next appointment? Should she have a therapist if she doesn't have one? She hasn't seen her family since she was 3, right? So she has not seen her family since she was 3. So yeah, abandonment. I mean, that's trauma. That's attachment at a very critical juncture of a child's development, right? And the problem is that mental health will not provide therapy because they will say that she can't benefit. So then I would think about art therapy, right? Or I would think about PERMA. What are other opportunities outside of therapy where this person can experience positive emotion, meaning a sense of achievement or accomplishment, right? It doesn't always have to be in the, in the confines of a therapeutic clinical setting. It's helpful. I can see how labeling her behaviors as manipulative could be really damaging to the supports that she receives, especially since she's not able to understand cause and effect fully. Lauren said that. Thank you, Lauren. And it is very damaging, right? And START specializes in, we are a mental health crisis safety net service. So people do not come to us when things are going well. And one of the things that we often say is that their reputations often precede them, right? And lead providers to make a lot of assumptions that they may not even be or are not cognizant that they are making, just based on what they see on paper, just based on what they've been told. This is why having a really firm grounding in those values and principles that we talked about is so important when you're talking about mental health and IDD, because it is a very complex interplay, right? Of this, it's a socio-cultural phenomenon, right? And you are not the diagnostician, but you are one of the shepherds, right? And you're in this very unique and valuable position where you can ask these important questions that can lead to change. You're not the one doing it, but you may be the one that spurs it. You might be the one that starts to challenge a narrative, right? About someone. Maybe Harmony isn't manipulative. Maybe she's just really desperately trying to get her needs met and doesn't have the skills to do it. Penny, I love how you're thinking about volunteer opportunities, like thinking about her strength of, social intelligence and her zest and her outgoing personality. Like let's find some engaging, meaningful opportunities where she can engage with other people and have those positive experiences. What else? Look back at those discussion prompts. If you were a member of Harmony's team, what do you think? What questions might you ask? So Lauren would ask about communication needs, right? When was the last time that she had a neuropsych eval? Let's look at the communication section. Let's look at the language section. And then what does that mean? Who can help us interpret this too, right? You don't have to be the expert in everything. You can just be the expert in asking good questions, the expert in curiosity, right? Does this team understand what these functional communication evaluation results means? If not, let's look at it together, right? Let's see if it makes sense based on what we understand about Harmony. Oh, so she talks, she can talk a good game, right? Sometimes we call this cocktail party syndrome, right? Where she can carry on a conversation, she can engage with you like the best of them. She's a wonderful conversationalist with surface level type of conversations, right? Talking about the weather, talking about things that she's familiar with or that she's interested in. And yet, what she is able to take in and process from those conversations, or from conversations that may be a little bit more critical, talking about the consequences of her actions, right? She is not able to process them. Does everybody on the team understand that? Could that be part of the root cause of her being characterized as manipulative or defiant? Oh, she knows the rules and she's choosing to break them, right? Rachel, I love that question. How does Harmony tell her story and describe herself? So really sort of putting that at the center of the dialogue. Who is Harmony to Harmony? How does our understanding of Harmony match that or mismatch that? Medication side effects, Audra, thank you for bringing our focus to that biomedical. We always want to rule out medical stuff, even if there isn't a medical need documented, right? What might be present that's contributing to this behavioral presentation, right? So what meds is she on? What potential side effects could she be experiencing? Environmental issues. So you could take a look back at that social determinants of health wheel, right? Look at some of those different domains. I love this question. Where does Harmony feel the happiest and most supported? That's a question we ask in a lot of different ways and start too, because we want to build off of those successful experiences, those successful places, spaces, and faces, right? So one of the things that we might hear is, you know, Harmony only does well with this one DSP because that DSP gives them whatever they want, right? That is one story. That is one perception. Let's take a closer look, right? Maybe it's because this DSP has a way of really sort of actively listening to Harmony's spoken and unspoken communication, right? Maybe there are things that we could learn from Harmony's DSP, right? That could be mimicked in other environments, which would promote consistency, which we also know is very helpful in a trauma-informed approach. That predictability, that sense of safety, right? Where is that present in Harmony's life and where might it be missing? Where can we take our cues? So looking at what's strong rather than what's wrong. And that is a core approach in positive psychology. Audrina, she responds well to structure and positive recognition. What do these things look like? And what's observed as helpful or promoting positive behavior? Ding! Those are just really broad statements in this vignette, right? That could really be teased apart. What does her schedule look like? What does structure mean to Audrina? You kind of got to channel your inner 3-year-old here, you know, because like, you know, how 3-year-olds are always like, why? 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 And they're not asking why to be annoying. They're asking why because they're curious about the world and everything. So channel your 3-year-old, right? Don't take anything at face value, right? She enjoys structure. Why? What does that structure look like? What does structure mean? Right? She likes positive recognition. Well, that comes in a lot of different ways. When I hire new team members, I ask them what positive recognition looks like for them. Because some people like public, loud shows of positive recognition. Other people like little quiet notes, right? Or, you know, they get embarrassed by loud shows of public recognition. I like to know that, right, about people I work with. It's the same thing for Harmony. What does this positive recognition look like? How can we build in more opportunities for that? And not in a manufactured, inauthentic way, but how can we celebrate moments of joy? Micro accomplishments. What does she want her schedule to look like? And what kind of help do staff need to help her? Debbie, I love that question, right? We're all in human services because we are helpers, right? We need help to help, right? So joining together collaboratively, again, this is no shame no blame. There is no one person or provider who we are pointing our fingers to, because our shared goal is the well-being of Harmony, right? So where is it working? Where is Harmony experiencing well-being, right? What does she want her schedule to look like? And what does it look like now? What are the barriers to getting it to where she wants it to be? Are there steps to get there that we can structure in and help her to understand? Rachel says she keeps returning back to the treatment and supports question. And do they promote well-being? I wonder how the team at Respite is interacting with Harmony. Does her list of diagnoses impact how they interact with her? How has this contributed to the conflict, right? So all this vignette says is that she's on hiatus from Respite, right? She's had numerous conflicts with the Respite provider. Remember how we talked about how inconsistent approaches can be a stressor for people with impacted executive functioning, right? So have we asked any questions about the Respite provider? What's the nature of the conflicts, right? What do they need? What does Harmony need? How can we help to support that? We don't know anything about that right now. This is a vignette that is open-ended, right? So as a care coordinator, what are your entry points? What are your questions? And respite's really important for Harmony, I'm sure, and for her providers, for her residential providers, husband and wife. They have grown kids that are out of the house. Harmony lives there. She's had some day programming and work opportunities, but everybody needs a break sometimes, right? And making those planned breaks versus emergency crisis breaks is also very important. Yeah, Amanda, root cause, right? It's sort of like that analogy of peeling back the layers of the onion. And I think far too often in the lives of people with IDD, folks just look at the outer layer, right? There's not a whole lot of interest in peeling back those layers. And so we see an externalized symptom or a behavior, as they're often called, and then people I've been doing this work for nearly 2 decades. She has behaviors. I'm from New England, so I'm going to use a New England accent, right? She's got behaviors. Well, what does that mean? I have behaviors. Do you want to know what they are? Right? What are you talking about? And so that's when you might ask a motivational interviewing type of question. Tell me what those behaviors look like. Right? Behaviors could be so many things. Don't rely on labels. Ask for that detail. That's going to help you get to the root cause. That's going to help you have a solid understanding of a person's whole biopsychosocial presentation, not just one piece. And that's going to help you get to the root cause. So yeah, as a care manager, as a care coordinator, I'd want to know what's going on. How can we lift the hiatus? A paid friend to develop, or developing appropriate friends at places that she wants to be. That's great, right? So a DSP, right, who might facilitate some work around social skills, looking and seeing if there are, sort of social peer groups. I think someone else mentioned that earlier in the chat. Peer groups are huge. We all need connection and we all need natural support. To the best of my knowledge, I don't have paid friends. I can't confirm that, right? But I'm pretty sure that all of my friends are not paid to be friends with me, right? So how can we find opportunities for Harmony to make natural organic connections with people, right? That might take some training, and it might be framed in a way of let's work with your provider, your DSP, right, to focus on like what makes a good friend and do some role plays, practicing, right? But ultimately finding those spaces where she can connect. She's artistic, so art therapy would be wonderful from a therapeutic, expressive side. But how else could she share her talents with other people? An art class, a painting class. And it doesn't need to be for people with disabilities. And in fact, I would recommend it's not. All right, I think Rachel's going to give me the hook in just a minute here. So I just wanted to say thank you very much for engaging in today's presentation, in all of your thoughtful brainstorming. I do hope that this was helpful to you in thinking about your role as a case manager and thinking about the mental health needs of people with IDD. We, in 55 minutes, were able to scratch the surface. So I hope you'll consider enrolling in one of our upcoming courses. We'd love to have you there. And thanks for having me today, Rachel. It was an honor to be invited.
Thank you so much, Beth. I love it when you come and present. I learn new things every time. And thank you everyone for attending today and participating, whether that was unmuting or dropping things in the chat. It's way more exciting for all of us when we participate and have a conversation. So much appreciated. I just dropped that survey link in the chat again. If you want a certificate of attendance or those CEUs from the Utah Social Work Association, be sure to fill that out. We appreciate you completing it anyway so that we can improve our future sessions. I will also drop my email in the chat again. So if you have any questions about our ECHO series or materials, or if you'd like to sign up for the course, the full 6-session course, you can reach out to me. I'll help you do that. And then we have just a few minutes left. I think if you have any questions for me or Beth, if you're opening to answer a question or two before we hit our stop mark at 1:30, you're welcome to stay on and ask a question, or you can hop off a few minutes early. We can wrap up for today. Thank you so much, everyone.